Imagine you're about to have a medical procedure, and you ask one simple question: how much will this cost? In almost any part of your life, that's an easy question to answer. In healthcare, it's one of the hardest questions to answer before the service actually happens. Today we're going to change that. You'll learn what a patient estimate really is, how it's calculated, what the law requires, and why getting it right decides how much provider collects and whether patients come back. Let's get started. Here's the heart of the problem. A patient estimate is a number you give a patient before care that tells them what they'll owe out of pocket. That sounds simple. The difficulty is that the number depends on three moving parts: the patient's insurance benefits, the provider's negotiated rate for the exact procedure, and where the patient stands against their deductible on that specific day. Get any one of these wrong, and the estimate is wrong. So let's build the number up one piece at a time. Now let's start with a clean definition. A patient estimate is a personalized projection of what a patient will owe out of pocket for a service, produced before that service happens. The word that matters most is personalized. This isn't a list price, and it isn't an average. It's specific to this patient, this plan, and this procedure. Hold on to that, because the entire challenge of estimates comes from making one number both specific and accurate. So what goes into an estimate? Three data streams. The first is the patient's benefits, which you pull through a real-time eligibility check with the payer. That tells you the deductible, how much of it the patient's already met, the coinsurance percentage, any copay, and the out-of-pocket maximum. The second is the contracted rate, also called the allowed amount. This is the price you negotiated with the payer for that specific procedure code. It isn't the chargemaster, and it isn't the sticker price. It's the negotiated rate, and confusing those two is the single most common reason estimates come out wrong. The third is the visit itself, the actual procedures, the place of service, and any services you reasonably expect to come with it. Combine those three, apply the cost-sharing math, and you've got the patient's number. Now, why does any of this matter? For years, the patient was a small slice of a provider's revenue. The insurer paid most of the bill, and you could collect the rest later. That's changed. The average deductible for single coverage reached $1,886 in 2025, and patient responsibility is now roughly a quarter of every claim dollar. Here's the catch. Patient dollars are the hardest dollars to collect. Providers recover less than 55% of patient balances after insurance, and once a balance ages into collections, recovery can fall to around 10%. The lesson is about timing. Money you collect before the patient leaves is money you actually collect. And when you do this well, the payoff is measurable. Avita Health rolled out patient estimates and raised its pre-service collections by 47%. The Health First health system lifted upfront collections by 27% and brought in more than $2 million upfront. The reason is plain human behavior. 65% of patients are more willing to pay when you hand them an estimate. There's a second payoff that providers tend to underrate, and that's retention. In Experian Health's 2026 survey, almost half of patients said they delay or forfeit care without an accurate estimate. And in a separate survey, 56% said they'd switch providers after a poor billing experience, a figure that rises to 74% among patients aged 18 to 26. A clear estimate does more than help your billing. It's how you keep your patients. There's also a legal dimension now. The No Surprises Act, which took effect in 2022, created the good faith estimate. If a patient's uninsured or paying cash, you must give them a written estimate of expected charges. The deadlines depend on timing. If the service is scheduled at least 3 business days out, the estimate's due within 1 business day. Schedule it 10 days out, and you've got 3 business days. If the patient simply asks, you've got 3 business days from the request. 2 numbers are worth memorizing here. The penalty for non-compliance runs up to $10,000 per violation, and a patient can formally dispute the bill if the final charges come in $400 or more above the estimate. So a low estimate creates real financial exposure on top of the damage it does to trust. And the rules are still moving. The No Surprises Act also describes a version of this for insured patients called the Advanced Explanation of Benefits, or Advanced EOB. Here's the idea. You send an estimate to the patient's health plan, and the plan tells the patient what to expect. Enforcement of that piece is on hold while the rules get written. It's the most likely next requirement, and organizations that already produce accurate estimates for insured patients will be ready the day it arrives. Now let's work the math together, because this is a step that decides whether your estimate is right. Take a procedure with a contracted rate of $2,000. Our patient has a deductible of $1,886 and has already met all but $500 of it. Their coinsurance is 20%. Step 1. The first $500 of that $2,000 goes straight to the remaining deductible, so the patient pays $500. Step 2. The $1,500 that's left is subject to 20% coinsurance, so the patient pays $300 and the plan pays $1,200. Step 3. We check the total against the out-of-pocket maximum, and here it's under the cap, so nothing changes. The patient owes $800. What happens if you use the chargemaster price, say $4,500, instead of the $2,000 contracted rate? Your estimate would be off by thousands. That's why the contracted rate is everything. Now, if the math's that simple, why are bad estimates so common? 4 reasons. First, eligibility data lags, so the deductible figure you pull can be out of date. Second, Contracted rates change constantly and vary by payer, plan, code, and location. So a rate table you don't maintain falls out of date without warning. Third, you don't know the exact procedure codes before the visit. And fourth, many encounters involve several providers at once: a facility fee, a physician fee, and an anesthesia fee, each with its own contract. Accuracy isn't a question of how careful your staff is, it's a question of the quality of the data underneath them. That brings us to how you actually produce these estimates. The manual way puts a staff member on every one, checking eligibility by phone, looking up rates in a spreadsheet, doing the math by hand, often after the patient's already left. It's slow, it's error prone, and it doesn't scale. One person manages maybe 50 to 100 estimates a day. The automated way verifies eligibility in real time, applies the correct contracted rate, generates the estimate in seconds, delivers it to the patient by text or email, and attaches a payment link so they can pay on the spot. One woman's health group needed 445 estimates a day to stay compliant, which would have meant hiring up to 8 people. Automation handled the volume and saved them as much as $344,000 a year. So if you're evaluating a tool, here's what to look for. Ask how it sources and updated contracted rates, because an estimate built on the ChargeMaster is wrong by design. Confirm that it checks eligibility in real time, not from a stale file. Make sure it meets the No Surprises Act deadlines automatically and logs every estimate for audit defense. Look for delivery through the patient's preferred channel with a way to pay attached, and check that it fits the systems you already run. As one example, MD Clary's Clary Flow is built around these exact requirements: applying contracted rates in real time and delivering estimates with a payment link. Whatever you choose, judge it on the data and the workflow, not on the demo. Let's pull it together. 5 things to remember. 1. A patient estimate is personalized to the patient, the plan, and the procedure. 2. Build it on the contracted rate, never the charge master. 3. The No Surprises Act already requires good faith estimates, and the penalties are real. 4. Accurate estimates raise upfront collections and keep patients from leaving. And 5. Accuracy comes from your data and your automation, not from working your staff harder. That's the full picture. What a patient estimate is, how it's calculated, what the law demands, and why it pays for itself. And if you'd rather not build all of that by hand, that's where Clarity Flow comes in. It generates accurate patient estimates from your contracted rates, delivers them to patients with a payment link, and keeps you compliant with the No Surprises Act and its good faith estimate deadlines. If you want to see it work, the link to book a demo is in the description below, along with a full written guide on patient estimates. Subscribe for more in the business of healthcare. Thanks for watching, and I'll see you in the next one.